So in the US, value-based healthcare is a huge topic in the news of debate, and it's a very big concern at the hospital level. And the concept, of course, is a great one. It's that better health is related to easier access, and that we would have access to price and quality information. Patients would have better care coordination, and that they would have an overall better consumer experience. So this value-based healthcare tries to reward providers for helping patients to improve their health. So all of our patients in the US get measured by these surveys, the Consumer Assessment of Healthcare Providers and Systems surveys. And this score is used to give us a report card about how we're doing, how we could improve our care. And the goal of the survey is really to make sure that patients are getting needed care, they're getting their care quickly, to measure how well doctors communicate, and the health plan's customer service, and how patients rate their healthcare plan or their insurance. But what do the questions actually look like on the survey? Well, the questions really look at things like, is the facility clean? Are the clerks and reception courteous? Does check-in run in smoothly? So things that we would not feel are necessarily directly related to our providing of care. So you may ask yourself, will the hospital cafeteria food ultimately influence the way my healthcare is reimbursed? And so my answer to that is that we need better data about patient outcomes and satisfaction after spine surgery, that we need to better define what value-based healthcare is. So obviously, degenerative cervical myelopathy is the most common reason for spinal cord dysfunction among adults, and surgery is often recommended, as we recently heard. The goal is most often to try to prevent worsening symptoms and to really lessen the impact of current symptoms such as poor balance and gait. So how do we define value? So we asked 4 key questions. Do patients report outcome in the MJOA or other patient surveys? What is the time course for change in PROs? Do they stabilize at, say, 3 or 6 months? Are patients satisfied with these results, and would they decide to have surgery again? So we performed a prospective cohort study of adult patients undergoing elective surgery for myelopathy at our single academic center. We included those with myelopathy defined by the treating surgeon, so it was based on the history, imaging, physical exam, so 1 or more of the following symptoms: hyperreflexia, clonus, gait dysfunction, clumsy hands, or bowel or bladder dysfunction. And again, excluded those with trauma, infection, pregnancy, central cord syndrome, or any other neuromuscular diseases such as multiple sclerosis. For health outcomes, we measured the modified Japanese Orthopedic Association survey and the recovery rate. And for patient-reported outcomes, we measured the Neck Disability Index and the short form 36 physical component scale and mental component scale. For satisfaction, patients took an expectation survey. This is a 5-point Likert scale, and we dichotomized the results to extremely and somewhat likely versus the other answers. The questions were, how would you rate your satisfaction with your spine surgery so far? And if you could go back in time and make the decisions again, would you choose the same treatment for your condition? So the time course, we measured all of these surveys within 1 month before surgery, and then after the surgery, 3, 6, 12, and 24 months. We used linear mixed models to try to identify characteristics that were significantly associated with health outcomes, and to look at the time course of change in outcome up to 24 months after surgery. And I got informed consent and IRB approval. So these are the patients that were enrolled. 102 prospectively and continuously enrolled, of whom 10 were lost to follow-up at 24 months after surgery. The mean age was 54.9 years, just over half were female, and most were Caucasian. Just under a third had a high school or less education, workman's compensation or legal litigation involved with the surgery was 6.6%. And most people had very few comorbidities, so their comorbidity index was 0 in 74% of patients. The duration of symptoms in most patients was over 9 months, and about 30% had T1 or T2 weighted signal changes on their clinical MRI. The majority of those were T2 weighted changes. And we also measured kyphosis on the MRI, and 64.4% had kyphosis. For surgical approach, about 40% had a surgery from the front, 47% from the back, and an anterior and posterior approach, and almost 12%. We added up the number of levels treated by decompression, fusion, and instrumentation. So this is total of each number of levels of each, and the mean was 6. And the baseline health outcomes, again, the MJOA indicated moderate disability, 13.4, NDI, 38.9, also moderate disability, and the SF-36 PCS, 35.5, whereas the mental component scale was 43.3, which is closer to the mean for the population. So very much showing that physical dysfunction is much more prominent than emotional dysfunction. So do patients report improvement in outcome? Our first question. At 2 years, the MJOA, the mean improvement was 0.7 points. The MJOA recovery rate median was 14.3%, and actually 36% of patients achieved a cutoff of at least 1.5 points of improvement on the MJOA scale. Oh, it froze. Okay, so multivariate analysis, only the preoperative MJOA was associated with the 2-year MJOA. For a 2-year neck disability index in SF-36, the improvement in NDI was at least 15 points in more than half of patients, and improved overall by more than at least 20% in 70% of patients. For the SF-36 physical component scale, mean improvement was 6.3 points, and again, 53% achieved at least 15% improvement in their score. And we also saw improvements even in the mental component scale or emotional health, 4.7 points, with about 35% achieving at least 15% improvement. These improvements were associated with baseline score, comorbidity, duration of symptoms, kyphosis on MRI, and the number of levels treated. Our second question was, what is the time course for change in patient-reported outcomes? So what we saw was that for all of our outcomes, there was improvement at each time point compared to before surgery. So 3, 6, 12, and 24 months. The MJOA improved, but was not statistically significantly different over time. NDI plateaued at about 6 months, so it remained improved out to 24 months. SF-36 PCS plateaued earlier at 3 months and again remained improved at 24 months. And the mental component scale plateaued at a year and remained again improved at 24 months. So our next question was, are patients satisfied with these results? And the majority were extremely or somewhat satisfied at 2 years post-op, 75%. And when we looked at the change in satisfaction pre-op to, at 3, 6, 12, and 24 months, we saw really no significant difference in that satisfaction. And would they decide to have surgery again? So most would, definitely or most likely make the same decision at 24 months after surgery. 73% would do this again. And again, no significant changes in decision-making between 3, 6, 12, and 24 months. So to summarize, do patients report improvement in outcome? Yes. In all of the measures we use, they reported improvement. What's the time course? It's different for each measure. The MJOA is stable at 2 years. NDI peaked at 6 months and remained stable at 2 years. And SF-36 peaked at 3 months. SF-36 MCS peaked at 12 months. So one might wonder if we really need to follow patients out to 2 years when they really are stabilized well before then. Are patients satisfied with these results? 75%, extremely and somewhat satisfied at 2 years. And would patients decide to have the surgery again? 73% definitely or most likely would have that surgery again, even out to 2 years after that surgery. So, will the hospital cafeteria food ultimately influence how healthcare is reimbursed? Maybe. But we showed that surgery for myelopathy results in improved patient outcome, and the majority of patients are satisfied with their surgery up to 2 years after surgery and would do it again. I think in the future, promise measures are new outcome measures that are being used more rapidly. They're much faster for patients to do and much more efficient. And they have a better ceiling and floor effect, and that may be where we go instead of doing these legacy measures. And finally, analysis of cost is going to be very integral in trying to prove the value of our surgery. Thank you.